Welcome to this overview of an atrial fibrillation ablation workflow focused on allied health professionals. Are you familiar with the most common arrhythmia found in patients today? Sometimes called AFib, atrial fibrillation is characterized by random, chaotic contractions of the atrial myocardium. Patients with AFib may have an atrial rate of 400 beats per minute or more. On an EKG, atrial activity is no longer represented by P waves, but by erratic baseline waves called fibrillatory or F waves, which occur between narrow QRS complexes. Recommended treatment includes electrical isolation of the pulmonary veins. By the end of today's presentation, you should be able to do the following. List the stages of an atrial fibrillation workflow. Connect relevant Biosense Webster technology and products with each stage of the procedure. And describe key moments during the atrial fibrillation ablation procedure. Here is a typical workflow for the atrial fibrillation ablation procedure. Case prep typically includes setup of equipment, preparation of the patient, anesthesia induction, and intubation. Access includes sheath and catheter insertion, followed by introduction of an intracardiac echocardiography or ICE catheter. Transeptal puncture is then performed, and catheters are placed in the heart. Mapping includes creating a three-dimensional map of anatomy and electrical data from the heart chambers. Ablation involves use of special catheters to deliver radiofrequency or RF energy. Finally, endpoints for the procedure include validating electrical isolation of tissue where RF energy was delivered and the absence of additional arrhythmias. First, let's discuss the Carter 3 system equipment setup, electrophysiology or EP lab staff, and considerations for the procedure. The Carter 3 system is an advanced mapping system that creates real-time, three-dimensional maps of the patient's heart. It also captures electroanatomical data to be stored and displayed using specialized catheters. Diagnostic and therapeutic catheters can be visualized within the heart chambers. This helps the physician to diagnose, interpret, and treat heart arrhythmias. Here are the components of the Carter 3 system. The Carter 3 system patient interface unit and workstation connect catheters and other EP equipment to enable creation of accurate maps of the heart. The location pad is a magnetic device placed under the patient table and connects to the patient interface unit. Back and chest patches are adhered to the patient and connect to the patient interface unit via the patch unit. These patches are used to visualize catheters within the heart. Once this equipment is in place and the procedure begins, movement by the patient and/or the location pad may alter the quality and accuracy of the Carter 3 system map. This is important to keep in mind when using pillows, repositioning the patient, or if the patient begins to cough during the procedure. A standard 12-lead ECG is applied and goes directly into the PIU. Other ECG and defibrillator patches may be placed for monitoring. Fluoroscopy equipment may be used to verify catheter placement. Here is an example of a typical EP lab setup, including the Carter 3 system. There are various people who may be working together during an ablation procedure. Roles and responsibilities vary by state and hospital, so check with your institution for specific responsibilities. Electrophysiology physicians, fellows, and advanced practice providers may obtain vascular access, perform catheter manipulation, pacing, and ablation. Nurses and technologists may be responsible for patient preparation, medication administration, monitoring, and documentation. They may prepare the patient table and hand off equipment to the sterile team during the procedure. In some EP labs, nurses and technologists also assist with vascular access and running the pacing systems. Technologists may also manipulate the fluoroscopy equipment. Each hospital and state has unique responsibilities assigned to each member of the lab staff. Anesthesia providers may provide sedation and airway management, and in other labs, this may be done by the EP nursing staff. J&J MedTech electrophysiology representatives may also be present. Reps may help operate the Carto3 system workstation and provide valuable product information to physicians and lab staff. Let's talk about the next phase of the procedure, groin access and use of intracardiac echocardiography, also called ICE. During this phase, the patient is now fully sedated, and groin access is obtained in order to place catheters in the heart, including an intracardiac echocardiography catheter. Watch this short video to see an example of what may happen during this phase of the procedure.
So in terms of our accesses, we have one access for a short sheath, and that's the sheath that we'll be using to do our intracardiac echo. And then we'll also use that sheath to put our coronary sinus catheter in, if we so choose to use. And the second access is going to be for our deflectable sheath, the Visigo. I'm going to start with a 9 French venous short sheath. 9 French sheath is in. Can we give the patient 10,000 of heparin, please? The patient has been anticoagulated. They're taking Xarelto. Their last dose of Xarelto was yesterday evening, so it's basically uninterrupted, or it was yesterday. And so we typically, our protocol is to leave the patient on anticoagulation. Okay, going in with the Visigo sheath, so I'm going to basically, I advance the wire in. There's no resistance. And then I put the wire in as far as it goes without resistance, and I just insert the sheath about 5 or 6 centimeters in, so I'm at least in the vessel, and we're just going to leave it there. Okay, so here you see the Visigo sheath. There are electrodes on the end there so the sheath can be visualized, and it's plugged into the patient interface unit. Okay, Visigo sheath is in. Okay, we'll leave it like that.
Once sheaths are placed and the catheters have been advanced into the heart, the physician may use the AccuResp module to track the patient's breathing cycle. When a patient breathes, the heart normally moves about 5 millimeters in the atria and 15 millimeters in the ventricles. But deep breaths may cause up to 30 millimeters of variation in motion. This variation may impact accuracy of the mapping data. The AccuResp module uses interpatch communications to track the patient's breathing. With information from the interpatch communications, the system creates a respiration graph. This graph is then used to set a respiration gating threshold. This threshold defines the expiration phase, or the consistent time when the system should capture data related to the three-dimensional electroanatomical map. Changes to the patient's respiration cycle may lead to incorrect gating. It may be helpful to discuss respiratory settings with the EP physician when mechanical ventilation is in use. Following use of the AccuResp module, intracardiac echocardiography may be used to create and display a Carto3 system three-dimensional map. An intracardiac echocardiogram is an ultrasound image taken from inside the heart. The CartoSound module integrates real-time intracardiac echocardiography images captured with the SoundStar ultrasound catheter and a compatible ultrasound system, accurately displaying them three-dimensionally on the Carto3 system. Using this technology, 3D mapping can display anatomy of the left atrium, transeptal puncture site, and orientation of the esophagus. Watch this video to see this in action to see a few of these structures now. Now let's talk about the next phase of the procedure, the transeptal puncture. In order to electrically isolate the pulmonary veins, the physician must cross the interatrial septum and gain access to the left atrium. During this step of the procedure, a physician can perform a transeptal puncture and gain access to the left side of the heart using the Cardiovisigo bidirectional guiding sheath. This sheath is different from other transeptal sheaths in that it is steerable and can be visualized on the Cardo3 system three-dimensional map. Here you can see the Cardiovisigo bidirectional guiding sheath visualized on the Cardo3 system as it passes from the right atrium into the left atrium at the transeptal puncture site. During this step of the procedure, the electrophysiologist may also request administration of anticoagulant medication and monitoring of blood clotting ACT levels throughout the remainder of the procedure. The next step of an atrial fibrillation ablation procedure is the mapping phase. During this phase, electroanatomical data may be captured and phrenic nerve pacing may be performed. The Cardo3 system is an electroanatomical mapping system. Let's break down what electroanatomical mapping means. First, electro refers to the electrical data the system collects from intracardiac electrograms. Next, anatomical refers to the three-dimensional location information of the detailed cardiac anatomy and the real-time location of the catheters inside the chambers. Finally, mapping refers to the ability to record and catalog the data collected in each location using Cardo3 system-compatible catheters. The phrenic nerve runs anterior to the right pulmonary veins. Some physicians will pace this area to delineate where the phrenic nerve correlates to the anatomical data of the map. When the phrenic nerve is stimulated, indicated with diaphragmatic movement, the location may be marked on the Cardo3 system 3D map. This helps the physician avoid the location when performing RF ablation. This is important to remember when paralytics are used, as they may inhibit capture of the phrenic nerve while pacing. After the mapping portion of the procedure, we are ready to ablate. Various techniques may be used during an atrial fibrillation ablation. Let's explore some of them now. The EP physician may use several different ablation strategies during an atrial fibrillation procedure. The most common, pulmonary vein isolation, involves ablation to electrically isolate the pulmonary veins. Linear ablation on the posterior or anterior wall of the left atrium may also occur in order to isolate additional areas of irregular conduction related to atrial fibrillation. Learning each physician's strategy can help you estimate how long this phase may take and anticipate when to alter your anesthesia care and the end of the procedure. The ThermoCool Smart Touch SF catheter's porous tip design enables maximum cooling efficiency with half the flow rate of the ThermoCool Smart Touch catheter. Once the catheter has been flushed and placed in the heart, it will continue to deliver a minimum irrigation of 2 milliliters per minute. During delivery of RF energy, the flow rate of heparinized saline through the tip of the catheter will vary based on the amount and time of RF energy used. Fluid from the ThermoCool Smart Touch SF catheter should be accounted for with the overall patient fluid intake. The ThermoCool Smart Touch SF catheter has broad procedural benefits, such as decreased procedure time, ablation time, and fluoroscopy time. Let's take a quick look at how radiofrequency ablation works and why it is relevant to patient care. Radiofrequency ablation works by heating the cardiac tissue. The more energy the tissue receives, the bigger the lesion created. Close monitoring of the esophageal temperature is an important consideration for anesthesia providers and EP lab staff during this procedure. One strategy to identify the location of the esophagus is to use the CardoSound module. As mentioned, one strategy to identify the location of the esophagus is to use the CardoSound module relative to where radiofrequency energy is being applied in the left atrium. Watch this video for an example of the CardoSound module. As you can see, the orientation of the esophagus appears to be closer to the right pulmonary veins. Strategies to monitor temperature of the esophagus may include a barium sulfate swallow and use of a multi-electrode esophageal temperature probe. CardoSound and the Esophistar catheter may also help to record and map the anatomical location of the esophagus. In addition to creating maps, intracardiac ultrasound can be used to monitor for complications in real time and offers many benefits, including decreased fluoroscopy and procedure times. The incidence of cardiac complications, including thromboembolic events and cardiac tamponade, were observed in one study to be significantly lower and driven by a significantly reduced rate of cardiac perforations. In a meta-analysis of studies examining use of ICE in ablation procedures, use of a sensor-based ICE catheter, such as the SoundStar catheter, reduced fluoroscopy time by an average 12.7 minutes and was associated with average procedure time reductions of 15.2 minutes compared to procedures without ICE. Finally, we have reached the last stage of the atrial fibrillation ablation procedure, validation. Here, let's discuss endpoints of the procedure, including confirmation of pulmonary vein isolation, medications used, and testing of additional arrhythmias. In order to confirm the goal of complete pulmonary vein isolation, pacing maneuvers may be performed to test for entrance and exit conduction block. Pacing is typically done with one catheter placed inside the pulmonary vein and another placed in the atrium to watch for capture of signal entering or exiting the pulmonary vein. Administration of medications such as these may reveal active electrical signals within the pulmonary veins. Pacing maneuvers may also be used to induce additional atrial tachycardias. These steps help the physician test the durability of the ablation lesions and determine if further treatment may be needed. After catheters and sheaths are removed from the patient, hemostasis is achieved. Some institutions may use groin closure devices, whereas others may hold manual pressure. This varies from provider to provider and can also be dependent on the patient's medical history. Communicating with the provider about their choice for hemostasis can guide medication delivery and sedation levels as the patient begins to wake up from anesthesia. Now that we have moved through the stages of an atrial fibrillation procedure, let's review various key moments that are particularly important for healthcare providers to be aware of. During case prep, patient positioning takes into account requirements for ideal patch placement, sterile preparation, ventilation, and sedation levels. During access and use of intracardiac echo, monitoring occurs for vascular complications. During and following transeptal puncture, the use of ICE can decrease risk of severe cardiac complications, including cardiac perforation, effusion, and tamponade. ICE may help detect intracardiac thrombus and reduce the risk of embolic complications. During ablation, monitoring may determine esophageal heating. As the procedure finishes during validation and the patient begins to wake up, coughing may lead to bleeding and a hematoma at access sites. These are just a few of the key moments the provider may consider during an atrial fibrillation procedure. Thank you for your attention. We hope this helped you understand the steps of an atrial fibrillation procedure and how J&J MedTech electrophysiology products may be used in this setting.